So the next speaker is Dr. Sockrider. Dr. Sockrider is our pulmonologist at Texas Children's Hospital, and she is seeing our patients over the last 10 plus years, both Mecp2 duplication and the Rett syndrome related disorders. She has humongous experience in breathing issues in Mecp2 Duplication Syndrome, and I'll let her to start her talk. Thank you so much. And just to let you know, Dr. Sockrider just had a knee surgery, and despite that she was able to participate. I want to specially thanks for her time and giving this talk. And thank you, Dr. Sockrider. You can start.
You're welcome. Can everyone hear me all right? Yes. It's a pleasure for me to be here with you. I wish I was actually physically here with you, but as Dr. Pelivan said, I'm going to share with you kind of the spectrum of breathing-related problems that we see with Mecp2 duplication, triplication syndromes. Let me see how to make my slides advance. Interesting. Okay. So there's kind of a range of different issues that I'll cover briefly, as well as some of the therapies that we use. So one of the things that's different in Mecp2 duplication than Rett syndrome is many children with Rett syndrome have irregular breathing, breath holding, and hyperventilation patterns, which we don't see as much in Mecp2 duplication. This is not an area that's as well studied, but we have some of the children with Mecp2 that have some irregular breathing or awake apnea, and the severity varies between patients and for a given patient over time. Hypoventilation is where a child that has a very shallow breathing pattern, and this can also vary across patients and for a given patient. And there's a number of factors that can relate to hypoventilation, which can lead to low oxygen or elevated carbon dioxide in the blood, particularly during sleep. All of us relax more when we sleep, so we don't breathe as effectively. But if you add on top of that some muscle weakness like hypotonia or spasticity where the chest wall's more rigid, body position issues, a person's breathing is generally deeper when you're sitting up or standing. So hypoventilation is not common in Mecp2, but it can be seen, and it can be seen more often in Mecp2 triplication. There is a special circumstance that is rare but can be seen with Mecp2 duplication, and this is neonatal encephalopathy with hypotonia and acute respiratory failure. And so these babies will have severe muscle weakness, apnea episodes, and respiratory failure. And this can affect the baby's ability to breathe, and they would need ventilator support. And even then, their prognosis is not very good. So obstructive sleep apnea is something that we also have concern about. It's not seen in all patients with Mecp2, but it can be seen more often with increasing age. And again, there can be various factors that can contribute to this risk, in addition to just some weakness of the upper throat and airway muscles. You can see this more with obesity. You can see it if a child has large tonsils and adenoids, and this can be seen even in children who don't have Mecp2. You can also see it more if a child has some mid-face hypoplasia. You can also see sometimes obstructive apnea develop with the use of a vagal nerve stimulator for seizure control, and sometimes that requires some adjustment of the settings or some support for the sleep apnea. Obstructive sleep apnea often presents with snoring at night. Usually it's worse when you're sleeping on the back. So for obstructive sleep apnea, in order to define it and to kind of characterize how severe it is, you would need a formal sleep study we call a polysomnogram. And if obstructive sleep apnea is present, then you may require treatment, and that could be tonsil and adenoid removal or often nasal CPAP or BiPAP support with sleep. This is using a device that uses some positive airway pressure, airflow to keep the airways more open. And if obstructive sleep apnea is severe and not responding to treatment, then rarely we'd need to think about a tracheostomy. Now, scoliosis or kyphoscoliosis is curve of the spine, and this can develop over time. It's actually more common in Rett syndrome, but it has been reported in over 25% of patients across studies. And bracing doesn't necessarily help. This requires monitoring and orthopedic evaluation. And where it comes into play for the lungs is if the curve involves the upper thorax, the upper spine, then it can limit how the lungs expand or cause one lung to be more limited in its expansion. And if it's progressive, then you may require surgery to stabilize it. So this gives you a restrictive lung problem because it affects the chest wall and muscles. Now, one of the things that is quite common with Mecp2 is the risk of recurrent respiratory infections, and particularly recurrent pneumonia. And this has been described in at least 75% of patients, and this can result in frequent hospitalizations. Other types of infections have also been described, ear, throat, sepsis. I believe you're going to have another talk about immune issues, but there are immune problems that have been described in patients, including a low IgA, immune globulin A, or IgG2. And so getting immune studies may be useful. And certainly recurrent infections is one of the things that could lead to an early death. Aspiration pneumonia is a particular concern and one that we try and watch out for and be suspicious of, particularly in children who are having swallowing problems. Aspiration can also occur with acute issues such as during a seizure or an acute illness or infection. So if you have some mild swallowing issues, you're not going to perform as well, and you may be even more challenged when you're in a situation where you're weak, where you're feeling sick, or when you're out of control, like in a seizure. Drooling also can occur because of autonomic nervous system problems with Mecp2. Now, one of the things that we worry particularly about is the situation where you have silent aspiration. So usually if you are swallowing and it goes the wrong way, you're going to react and you're going to cough and try and get that liquid or food out of your airway. But there are times where a child doesn't react with coughing or choking as one would expect. And we can see this on imaging studies where they'll do dye studies and look at their swallow, and they can see the dye going into the airway and there's no reaction. And this means that the child can be aspirating. You don't recognize it except for the impact that it has on the lungs. And so aspiration can result in a variety of symptoms, airway symptoms like bronchospasm of the airway that can cause wheezing, chronic cough, or chest congestion, bronchitis, chronic pneumonitis, just inflammation of the lungs, or an acute pneumonia. And over time, recurrent aspiration can damage the lungs and airways. So when we're trying to evaluate a child to see if they're at risk for aspiration or if that's part of why they're having chronic respiratory symptoms, a swallow function study can be done, and this can help us to see if oral feedings are safe. And there certainly are children that can handle puree or some foods, but they might have more trouble with thin liquids because liquids roll down the throat more quickly. And so there are times where we have alternative feeding that we need to consider. And even if they can take some oral or pleasure feeds, they may need to use a gastrostomy to take enough calorie intake without having to push too hard to safely get oral liquids or to spend the amount of time it might take to carefully feed the child. You also can use a suction machine to help with that excessive drooling or oral secretions. There are also medications that we use to help reduce excessive oral secretions, because sometimes too, children don't just drool out, but they let saliva pool in the back of their throat, which can be a risk for aspiration. Medications we use, all of the ones listed here, are basically drugs that are called anticholinergics, and that's how they dry secretions. And so glycopyrrolate is one that is a oral or G-tube medication. It comes as a liquid, or we often crush a tablet, especially if kids might be on a ketogenic diet for their seizures. They can't take liquids, medications. Scopolamine is a transdermal patch that people use often for motion sickness, like with cruises, and they'll tell you their mouth is dry. This is nice because it is extended action, sort of steady state, and you change it every 2 to 3 days, putting it behind the ear. Atropine eye drops can be used under the tongue, and they last for some hours. For severe cases where they really are at risk for aspiration, they cannot handle their oral secretions, then one could consider a laryngotracheal separation, we'll talk about in a minute, or a trach. So one of the things that's important for all of us when we have congestion in our chest is the ability to cough mucus. And certainly any young child is not as good at coughing or sneezing out mucus like an adult. And usually they won't spit out the mucus. Now, if a child brings mucus up to the back of their throat and swallow it, it's out of the lungs, and that's fine. But muscle weakness and poor tone makes your cough weaker, and immobility also limits the movement of mucus in the airways. We all have mucus, and as we move around, it comes up. We don't even realize it, but not moving really limits somewhat the movement of mucus in your airways. Scoliosis, as I mentioned before, can also affect not only the mechanics of your breathing, but also cough. And so not being able to get that mucus out of the lungs can lead to a problem that we call atelectasis, which is basically some collapse of some part of the lungs and the little air sac. So these x-rays, this shows you're losing the nice heart border. There's some atelectasis in this left lower lung. In this case, the whole right lung developed atelectasis, which actually led to shifting the heart over. So clearly we need to help these children keep mucus from building up in the lungs or blocking the airways, causing atelectasis. So there are different ways that we use to help mobilize airway secretions. Some children benefit from using a nebulizer like an aerosol mist that helps thin mucus. And this uses a medical air compressor and a mask with a nebulizer that holds the medicine. And you might use medicines like a bronchodilator, like albuterol, or you may use salmeterol, or use medications if they're having extra thick secretions, like with infection, use hypertonic saline, either 3 or 7%. And usually we'll pre-treat before hypersal with a bronchodilator. You can't mix albuterol with hypertonic saline. There are some children that might use an inhaled steroid for airway inflammation, but that's not needed for everyone. So we also have devices that we use that can sometimes help with airway clearance. And these are just examples. There are certainly different models and brands. So usually I'll have children who need this kind of support do treatments at least twice a day, sort of first thing in the morning to kind of clear out secretions that might have built up overnight, and then before they go to bed. But if they're sick or having a new infection, they'll go up to 3 or 4 times a day, and in the hospital, sometimes every 4 hours or so. So a cough assist device is a device that pushes air in and then kind of has a negative pressure, sucks the air back out, trying to induce some cough. And that's an example in that upper picture. And a percussive vest is another way of clapping on the chest, which one can also do manual clapping to help loosen secretions, but the child still has to be able to get them to the main airway and then cough them out. Repeated infections can cause damage to the airways and lungs. One of the kinds of damage we see is called bronchiectasis, which basically is just structural damage to the airways that makes them not clear secretions as well. And so these damaged airways just make things worse for an area to have recurrent pneumonia or atelectasis. This is not as well characterized in Mecp2, but in a study where they looked at some girls with Rett syndrome using a CT, they found that more than half had some evidence of bronchiectasis at 12 years of age. Another condition that's rare but can be seen is pulmonary hypertension, which is high blood pressure in the lungs. This has only been reported in the literature that I found in 5 cases, certainly is a serious and at times life-threatening condition. This high blood pressure in the lungs can cause significant low oxygen levels and stress on the heart. The diagnosis is suspected first by using an echocardiogram, and there are medications that are available to help control pH. Now, as I said, it's not common that we face the need for tracheostomy. A tracheostomy tube is a tube that's placed in the airway as an alternative airway so that the child can still breathe through their nose and mouth, but they're basically using that trach to both allow one to suction the windpipe directly and to use to attach a ventilator if needed to help them breathe during sleep. And so it's more stable for long-term use than like a tube in the windpipe that you might see in an ICU for an acute illness. There are some children that need positive pressure ventilator support if they had continued low oxygen issues, even with supplemental oxygen using a nasal cannula. If they had elevated carbon dioxide, that they couldn't blow off the carbon dioxide effectively. And if they kept having problems with atelectasis that just didn't allow them to breathe effectively. And a ventilator really can be used based on the person's needs. Some need it all the time, some with sleep, some just during an acute illness. But obviously, we'd like to avoid the need for this kind of support, and it's not something that we expect all children with Mecp2 to need. The most significant kind of intervention, I guess, and just because people wonder what it is, I put it in here, laryngeal tracheal separation. I have seen a few children have over the decades. This is for a child with severe aspiration. The surgery is done to close the larynx permanently so nothing can go down into the airway, which means the child also can't talk or vocalize. Often the children that this is considered for are nonverbal anyway. By closing that, they have a tracheostomy, and they don't necessarily need a ventilator. You can have a trach without a vent, but this can't be reversed. So this is pretty extreme, but there are children who are actually much healthier after this. In general, there are always measures one can think about to avoid respiratory infections. Obviously, no one does well with tobacco smoke exposure, so limiting that. Good hand washing, avoiding ill contacts, getting recommended immunizations, including annual flu vaccine. Consider pneumococcal vaccines. Now in the U.S., we have Prevnar 20 for strep pneumonia. The Pneumovax is also another additional pneumococcal vaccine. The strep pneumonia bacteria is only one type of bacteria that gives you pneumonia, but it is one that could be prevented some with a vaccine. Consider COVID vaccines. And then as we've talked about, managing airway secretions and trying to avoid aspiration, which also may mean managing safe feedings. So in summary, both Mecp2 duplication triplication syndromes can have lung and airway problems, particularly with increasing age. Respiratory infections are a common concern. Helping clear airway secretions and avoiding choking and aspiration can help avoid some of these lung problems and take steps to avoid infection as possible. And there is a need for more research on the respiratory and immune problems in Mecp2 and how to prevent and manage them. So I thank you for your time. I'm happy to take some questions.
Does this work? Yeah. Thank you, Dr. Sockrider. I wanted to start with one point. We did the IONIS biomarker study, where we had, I think, 12 Mecp2 duplication boys and male red patients in that study, 5 or 6. And I think one of the Mecp2 duplication boys only said that their child has obstructive sleep apnea. But we did polysomnography in the study, and all 12 patients had sleep apnea. This mild is not major, but definitely needs to be screened, I would say now, for the entire, all Mecp2 duplication patients should undergo. Why is it important? It makes your child tired, may cause fatigue, or if it's too severe, it may cause much more health problems. That's an important thing we found out in our study.
Yeah, it may not only affect like your oxygen levels during sleep, it affects the quality of your sleep. Sometimes the children don't sleep as deeply or as well. And so if you're not sleeping well, none of us do as well during the day. And it actually, if you have significant frequent drops in oxygen, that can increase your risk of pulmonary hypertension. There are various ways to manage sleep apnea, and I think a child that has findings of mild sleep apnea, we certainly look at the airway to see, are there big tonsils or adenoids that you can help the child with, manage obesity, and otherwise you would repeat a sleep study at least every year to make sure it's not progressing, because you can't just judge by looking at tonsil size. You can't judge well by the amount of snoring. You really need to be suspicious.
Yeah. Questions? Okay. I wanted to bring out the morning that you asked in the previous session, excessive mucus, right? Is this more excessive mucus, or they can't clear it up from the airway? What is your point on that?
Well, I think there's two things. One is there are children who have a lot of oral secretions, so saliva. All of us have some saliva, and we need it for good oral health. But there are children that drool a lot, and that extra saliva they can't always handle well and may aspirate. And so for those children, we're trying to use medication to sort of turn the faucet down some, not to overdrive. Now, there also are times where you have excessive mucus in the lungs, and especially if you get an infection or you have aspiration, you may make more mucus than usual in your lungs, and you've got to get that out. So anybody who has bronchitis knows that there's mucus, and a lot of parents would come to me and they'll say, oh my gosh, I can hear it. It's right here, and he can't get it up. And I wish I could reach it for him because it's just stuck. And that's what we have to work on, is ways to move it from the chest into the throat, where you can either suction it, or the child can swallow it, or they can cough it out.
Yep, thank you. And any other questions? I think we are all good. Thank you so much, Dr. Sockrider, for your time.
You're welcome. I hope your conference goes well. Good luck.